Welcome to Logic Medico, where we are understanding the concepts in medicine. The clinical examination of the larynx, direct laryngoscopy, is today's topic. This is a direct laryngoscope. We can see a blade. This is the blade out of stainless steel, which is there to depress the tongue and lift the mandible upwards. This is a scope. Through this, we can illuminate light and visualize the interior of larynx. So we'll see this. Direct laryngoscopy. It's a procedure in which there is a direct visualization of the larynx and the hypo pharynx. So that is called as direct laryngoscopy. Overall procedure is called direct laryngoscopy, and this instrument is called laryngoscope. Okay. These laryngoscopes can be a simple rigid scope like this to a dynamic fibro-optic video device. One wire like thing will be there, within that camera will be there. That camera is connected to the computer screen. Okay. Rigid laryngoscope are manufactured either as a single piece, this entire thing will be a single piece, or I already told you there will be a detachable blade, and of course with a light source and battery will be there inside this. This detachable handle and blade, the light source is energized, okay, and in operating position it can be kept over there to visualize the interior of larynx. A hook-on connection between the handle and blade is most commonly used because it's most convenient. Okay. So that's why the hook-on device is used. So this is how it is done. A non-dominant hand is used. Okay, here we can see the laryngoscopic blade. It's of various sizes depending on the size of the. When we ask the patient in pre-anesthetic evaluation to open the mouth, based on the position of the soft palate with respect to the tongue, we can decide the size of the blade. Okay, that is a different topic as such. So this is the laryngoscopic blade. Here, what is happening? The tongue is being pushed, okay, downwards and upwards. First, it's pushed down. For the patient is down. For here, the patient is lying supine. So here the doctor is pushing upwards. So the chin, along with this mandible, it's pushed upwards so that we can see the larynx. Otherwise, this is a curved course, right? It's going like this, oral cavity, oropharynx, then coming like this, laryngeal inlet, and then going straight like this. So this curved outlet, because of the lifting of the tongue and the mandible forward, now it will become a straight channel. Through the scope, the doctor can illuminate the light, and the interior of the larynx will be visible. So that's how it's done. The other hand can be used either to stabilize this is a mannequin, so it's supporting the head, but otherwise the lips can be wide apart by the dominant hand and the visualization can be better. So gauze piece can be placed on the upper teeth. That is especially important. These upper teeth can get damaged if you take this as a leverage point. So we should make sure that this blade doesn't touch the upper teeth. Otherwise there is chance of cracking and breaking of these upper teeth. So you can put a gauze piece over here. You can stabilize with the other hand. After lubrication of the laryngoscope is held in a non-dominant hand, usually the left hand. And the right hand, I already told you, is used to retract the lips and guide the scope into the laryngeal inlet. Okay, it is introduced. The laryngoscope they are talking is introduced by one side of the tongue, which is then pushed to the opposite side till the posterior 1/3 of the tongue is reached. Okay, so that is how it is done. So one side of the tongue you go and then push it to the opposite side till the posterior part of the tongue is reached. Then it is advanced, and when you are able to make out the epiglottis, kindly lift it forward. So you have to lift the tongue forward or across this should point 12 o'clock actually, or towards the corner of the wall, between the wall and the roof. This laryngoscope, other end of the laryngoscope should point at this angle between the opposite wall and the roof. So that is a correct position where you are lifting the tongue and the mandible forward, and then we should not use the leverage in the upper teeth and jaw. This I already told you. Otherwise, this upper teeth and this upper jaw, there will be trauma, fracture, especially in elderly. There will be they will lose their teeth. They come for some operative procedure and you are doing this laryngoscopy and they lose the teeth. Okay, so it will have some problem. Okay, so this is how we can see in the direct laryngoscope. So what is this? This is the posterior and lateral surface of the epiglottis. This is a free margin of the epiglottis. So what are these? These are the arytenoid cartilages. These bulges are the arytenoid cartilages. So what is this fold? Aryepiglottic folds. Aryepiglottic folds. Very good, excellent. These shelf-like projections on the upper plane is a vestibular fold. Vestibular fold. these shelves in the lower plane, which is white color margin, this one, this is the vocal cords. Below the vocal cord, obviously this is subglottic, and we can see some tracheal rings also. The posterior part is the hypopharynx or the laryngopharynx, and here pyriform fossa is there in the lower down. A continuation will be esophagus will be there. So this is most important. Posterior and lateral surface of the epiglottis is beautifully visible. Arytenoid bulges, arytenoid cartilages. Actually, in fact, this is a cricoid cartilage upon which the arytenoid is sitting. This is the arytenoid, right and left arytenoid. Connecting the two, these are called aryepiglottic fold. Together, this is called as laryngeal inlet. The epiglottis anteriorly, the arytenoid cartilages posteriorly, aryepiglottic folds on either side is called as laryngeal inlet. These pink color mucosal folds are called vestibular folds, whereas this white color fold, if you ask the patient to speak, these white color folds will move. That white color fold which is moving is called as vocal cords, and below that is the subglottic and the tracheal rings. Posterior to the arytenoid and the cricoid, this is the hypopharynx or laryngopharynx. Within the lateral wall of laryngopharynx, we can also make out pyriform fossa. Inferior to the pharynx, there will be esophagus. So this is in detail about the direct laryngoscopy. Thank you for watching and learning from Logic Medico. Kindly subscribe to our channel and press the bell icon. And don't forget to press the thumbs up icon if you like the video. Thank you.